Good morning, dear colleagues. I have another data from our register. So we present the results from the pharmacology and neurohumoral activation registry, which collects data on patients with chronic heart failure. The register contains 1,088 patients with chronic heart failure. And it's from 3 workplaces in the Czech Republic, which specialize in the care of patients with heart failure. Everybody is familiar with this slide, so let's go through quickly. According to the ASC guidelines, patients with heart failure are divided into 3 groups. Ejection fraction, reduced ejection fraction group is 40% and below. Then is a mildly reduced group, it's between 41 and 39%. And the last one is a group with preserved ejection fraction, and it's below 50%. The last group must have another criterion. It's elevated NT-proBNP, and at least one additional criteria, either diastolic dysfunction or hypertrophic cardiomyopathy or left atrial dilatation. And of course, all 3 groups must have symptoms and signs of the heart failure. Our methodology. We consider stable conditions to be when the symptoms and signs of the disease are unchanged for at least a month and effective pharmacotherapy is set. There were patients with ejection fraction below 50%. Patients were free from 3 cardio centers, as I said. These cardio centers are specific that we have patients with more serious conditions, such as before orthotopic heart transplantation or before left ventricle assist device. And these patients were outpatients, and patients were hospitalized too. These hospitalizations were elective. It was, for example, before implantation of ICD or before coronarography. The aim. The aim of this study was to determine whether patients with mildly reduced ejection fraction and reduced ejection fraction differ in clinical manifestation, laboratory findings, pharmacotherapy or epidemiology or comorbidities. And another goal was to compare 2-year prognosis between this group, and we have primary combined endpoint, and it was death from any cause or orthotopic heart transplantation or left heart support implantation. Now our file. Patients with reduced ejection fraction are more likely to be male, are older, have lower systolic blood pressure, and are less likely to be ischemic. So let's focus on this ischemic group. In not selected population, we would expect more ischemic causes of heart failure. But as I said, in our cardio centers, we very often have not so common causes of heart failure, for example, cardiomyopathies. Yeah, in our register, patients with with reduced ejection fraction have higher New York Heart classification, and in laboratories they have elevated concentration of NT-proBNP, urea, and uric acid. Now our comorbidities. There are no significant differences in presence of comorbidities and proportion of smokers and non-smokers. But you can see that hypertension is less often in a reduced ejection fraction group, mainly due to higher consumption of diuretics compared with mildly reduced group. And pharmacotherapy. Reduced ejection fraction group was more treated with loop diuretics and with mineral corticosteroid receptor blockers, and less often with thiazides. And it's because thiazides were included as hypertension therapy using diuretic effect in a mildly reduced group. But patients with reduced ejection fraction group have a bigger benefit from furosemide. Now you can see 2-year event-free survival without achieving a compound endpoint. You could see that prognosis of patient with reduced ejection fraction is worse. 2-year prognosis without reaching our combined endpoint was 82% in the reduced ejection fraction, but in mildly reduced ejection fraction it was 89.6%. So our conclusions. Again, patients with reduced ejection fraction in our research have a higher class of New York Heart Association. In laboratories, they have a higher concentration of NT-proBNP, urea. They are more often treated with loop diuretics and mineralocorticoid blockers and less of thiazides, and compared to patients with mildly reduced, patients with reduced ejection fraction have, of course, more severe heart failure and more pronounced neurohumoral activation and worse prognosis. And as I said, they do not differ in the presence of comorbidities. So thank you for your attention.
Many thanks for the presentation, and again, you were comfortably in the time limit, so no stress. And now we can discuss the paper. So are there any questions from the audience? Please raise the hands. Well, so I would like to ask you, when I saw this table with pharmacologic treatment, there was not mentioned ivabradine, so could you explain it?
Yeah, lots of colleagues ask me why there is not ivabradine, but it's because our patients very often have the highest dosage of beta blockers, and a lot of them have atrial fibrillation too, so we couldn't use ivabradine, so we didn't have it in this research, this data.
Yes, thank you. Other questions? So, if not, thank you again.
Thank you.